So it's really my pleasure to welcome Dr. Jessica Anderson, who holds a faculty appointment as Associate Professor and Director of Midwifery and Women's Health Services at the CU College of Nursing. Jessica's professional interests include maternal mortality, peer support, nitrous oxide for labor, healthcare policy, practice development, midwifery models of care, and doula care. She's received several awards. I won't name all of them, there are many, and she serves quite actively on a number of committees. She is the board chair of the Colorado Perinatal Care Quality Collaborative. Also my pleasure to welcome Britt Westmoreland. Britt's a recovery coach and perinatal doula with the University of Colorado's College of Nursing. Britt is the program coordinator and lead recovery coach doula for the university's Recovery Coach Doula program. She also serves as a recovery coach at the university's FQHC, where she works directly with adults with substance use and runs a youth program for teens impacted by substance use and/or the criminal justice system. Thank you so much for coming.
Well, perfect. Thank you for that lovely introduction. I just wanted, before we jump into the content of our presentation, is to give a little foundation to how this program came together. I am not a doula. I'm not an expert in substance use disorder, but I've been a longtime believer and supporter of doula care, midwifery care, and really involved in maternal mortality within the state. I've had the honor to sit on the maternal mortality review committee for the last 10 years. And during that time, and as the causes of death really started to become clear in our state, you start to see gaps, right? Gaps, opportunities. And my team at the College of Nursing, knowing the data from the state level, being a believer in doula care, believer in that people need more services in the perinatal space, we came up with this concept of a recovery coach doula. And so we've had our program in place for a little bit, for about 2 years, going on 2 years. And so that's kind of the background and the foundation of this program. So just real quick, before I hand it over to Britt, how we came up with the recovery coach doula. We know that we wanted to provide additional support, really from a foundation of doula care, right? Really supporting people in that perinatal space. And so we knew the foundations or the tenets of doula care could really serve a purpose in the role or the program that we were building. And so we know that doula care really cares for the individual from an emotional, supportive, non-medical approach. And so we knew we wanted to include those components. And then we also know that we needed the peer support piece as well. So what is our definition of a recovery coach doula? It's a person who's dually trained as a recovery coach, peer support specialist, and doula. And so how we've kind of built our program is that we've brought people on with that experience of peer support or recovery coach, provided the additional training for them to be a doula, and then given them the additional training to function and serve within our system. So I'm going to hand it over to Britt now to talk about our program.
I am Britt. I'll share my story in a little bit. Hopefully I work this correctly. So like in an overview, these are the components of our program. Of course, the recovery coach doulas. We also have incentives or contingency management, which are gift cards that are given just for participation, engagement with the RCD. And then you get extra money on the gift card if you're going to prenatal or postpartum appointments, if you have them, including pediatric care. We also run a Circle of Parents group, Circle of Parents in Recovery, who will be talking later, called Mothers United in Recovery. And this is an open statewide group held on Fridays via Zoom. And it's for anyone in Colorado who identifies as a mother with substance use disorder. So they can have adult children, they can be pregnant, anywhere in between. And then tailored care was a big component of this. We really work very closely with the midwifery team and the CU's pair team, including Dr. Kaylin Klee, and then our community supports, including Elephant Circle and Safe Babies and OTPs. So as Jessica mentioned, we do train peer support specialists. That is part of our goal, is to kind of disseminate the information. So through Elephant Circle is how we do that. That's our community doula partnership. They also, in addition to providing training and mentorship, they also are big collaborators in building and sustaining this program. And then this is the project team. So it's, the recovery coach doulas, some midwives, some research people, and doulas basically. And we meet every 2 weeks just to discuss, what's going on, what we want for the future, data collection, research, things that are working, things that aren't working. And that's myself and the other RCD right now, Felicia. And now I will explain what brought me to this work. So as a peer, I have lived experience. I've been in recovery from substance use disorder since October 9th of 2017, so 7 years now. Thank you. And before that, I am a survivor of childhood abuse and neglect, sexual assault, life-threatening intimate partner violence. I have been gang involved. I was involved in the criminal justice system at a very young age due to my substance and lifestyle choices. So all of that kind of came to a head in 2017. And really the intimate partner violence is what led me to recovery, just from how I perceived I was treated when asking for help, particularly from law enforcement, and getting out of that situation as someone who was using substances. I perceived that if I wanted help, I had to be sober, or at least seem sober. So that led me to recovery, and it kind of just stuck. And then I am from Texas. So in 2018, I moved here to Colorado. And then in 2019, I started my work in the field of recovery, worked in a bunch of different, what would you call it? Places. That wasn't the word I was looking for, but, and through my experience through working with different places, I was introduced to peer work. And that was shortly before I had my son. I was kind of, taught about what a peer was. And then I had my son in 2021. So I was 4 years into recovery at the time. And as I said, I was in active use in Texas. So it's not in my chart. Nobody knows about it. So as a mother with substance use disorder, I had decided in the prenatal period that I wasn't going to share my substance use disorder with anyone because it wasn't their business. And I didn't see a benefit to that. All I saw was them using it in a negative way and taking my baby. So I found myself in labor and delivery at 36 weeks. My water had broke. The father of my child is not safe or appropriate to parent. Neither does he want to. And that was established pretty early in my pregnancy. So he wasn't there. I had planned an induction. We all know how birth plans go, but I had planned an induction for my family from Texas to come up and be my support. Of course, my induction was not at 36 weeks, so I didn't have any support. So I was laboring alone. I was, in preterm labor, so very stressed out. And I had told the nurses that I didn't want IV fentanyl, that I was planning on the epidural, but I wanted to wait. And so I had said no directly to nurses twice to IV fentanyl, and explained that I just wanted the epidural. I gave birth during COVID, so laughing gas wasn't an option. It was either IV fentanyl, epidural, or nothing. And since I didn't trust the medical system, I had some misinformation about having to wait to get the epidural in order to still birth vaginally successfully. So I thought I had to be in active labor, like 7 or 8 centimeters. And I was in labor for 36 hours. So I wasn't anywhere near that. And I remember I was in the bathtub at one point, pretty much crying, saying I didn't want to do it anymore. I was like over 24 hours in, having regular contractions, just not dilating very well. And the nurse for the 3rd time asked me if I wanted IV fentanyl. That was her cure for me not wanting to be in labor anymore. And I had it at that point, evidently, so I disclosed that I was in recovery, and that's why I didn't want IV fentanyl. Disclaimer, that's not how everyone in recovery feels. That's just how I feel, that I didn't want fentanyl. And I perceived a change in our relationship pretty immediately. She didn't say anything about what I had told her. but the way that she interacted with me was very different after that. I did get a doula out of that. So that they withheld a doula from me for that long. But the hospital that I was at they had at the time a volunteer doula program. So I was able to have a free doula, which is how I was introduced to doula work and really saw the benefit of it. I was able to have a successful vaginal birth. My son was in the NICU for 5 days just due to being preterm. And again, not a lot of support, very stressful and traumatic situation for anyone. I did have a social worker come in response to what I said in the bathtub and offer me some residential treatment facilities as someone 4 years in recovery. So I politely said, I'm in recovery, thank you, but please leave. And that really reinforced the idea that I shouldn't have said anything to anyone because I perceived that as like social work coming in. I perceived that as them thinking that I wasn't safe to parent because I was in recovery. So that kind of led to some prolonged suffering postpartum, I think. I experienced postpartum bipolar disorder, which I didn't know was a thing until I experienced it and was diagnosed with it. I don't have bipolar disorder outside of the postpartum period, outside of this episode, so I didn't recognize what was happening. But I do remember I was very manic, right? That's part of bipolar disorder. So I was very manic. I was staying up all night. I was cleaning excessively. I was just doing the most. And I remember one night I took a video of my kitchen because I thought that I saw rats in my kitchen. So I took a video and I remember I watched the video the next day and the video was just of nothing. It was just of my kitchen, like nothing was happening. So I was like, oh, I think I'm losing my mind. So that was pretty alarming. And instead of reaching out, which is what I should do, I took that as another thing that people would say I'm not safe to parent. So I was like, oh, I definitely can't tell anyone I'm struggling. And I think the mania and the stress and everything that was going on, not having any support, also led to my substance use disorder being triggered, which again, I didn't expect that to happen. I was 4 years into recovery at the time and I started having really strong cravings for opiates. And I hadn't experienced that in 4, 5 years. I quit opiates before other things, so about 5 years at that time. And I didn't know what to do. I didn't feel like it was safe to reach out to anyone, again, because I thought they would take my baby. So it led to me pretty much white knuckling it for about 18 months. My son was about 18 months old before I went to a MAT doctor. I was like, it's not getting any better. I think I can either do something to stop it or it's going to lead to me using. So I went to a MAT doctor. I told them, hey, this is what's going on. I need some Suboxone. She said, I don't know if that's the best choice for you because you haven't used opiates in a very long time. And I basically said, I don't want to try anything. I know Suboxone works, so give me Suboxone. She respected my wishes, and then I realized what she was talking about. I started nodding out on Suboxone, which was very triggering. I remember I was talking face-to-face with my boss one day, and I could feel it in my face. There's just like an opioid high feeling that I get in my face. It's like tired. And I was like, oh my gosh, my boss is going to think I'm high. And then shortly after that, I was in the shower. I had switched to taking it at night. I was in the shower, nodding out, and that was the end of it for me. That was the last time I took Suboxone. I went back to the MAT doctor, and I was like, hey, you were right. I actually need naltrexone. So I was on naltrexone for about a year. Again, I was 5, 6 years into recovery at the time that I went back on MAT. And that really opened my eyes to, as Raquel was saying, the stigma and bias that people still experience with substance use disorder, regardless of if they're using or if they're not using. And also the deep fear of someone taking our children just because we have substance use disorder. So back to the program. Once someone is referred to us, which I'll explain how to refer to us, the client is connected with a recovery coach doula, so they're assigned to one of us. Ideally, we get people, as soon as they find out they're pregnant, which would ideally be in the first trimester. Obviously, that's not always the case, not even usually the case. But we support people throughout their pregnancy, all the way up into a year postpartum. We are, again, full spectrum doulas, so we do attend birth and labor. And our goal with people, how I explain it to our participants, our clients, is that we're here to support you in however you need in the realm of your recovery and wellness, which is pretty much everything in your life, of course, within our scope. And so we really just provide whatever resources and support they need in the moment, as well as a bigger picture addressing like stigma and bias and systemic issues. And then, of course, we help them in labor and delivery and educate them around what that looks like, and like nows and things like that. To be part of our program, someone has to be either pregnant or up to a year postpartum. We do have a special consideration for people who are Safe Babies Court involved. That's one of our community partners. They remain in the program up to 18 months postpartum, and that was a collaborative decision made between myself and one of my Safe Babies Court partners, and then approved by the team, because at 12 months is typically when permanency is established. So regardless of if it's a return home or not a return home, it's not a great time to lose a support. So we did extend it for those people. They do have to have a history of substance use disorder. They can be actively using, they can be 20 years in recovery, anywhere in between, it doesn't matter. They just have to have substance use disorder. If they're pregnant, they do have to birth at a UCH hospital or plan to birth at a UCH hospital at the moment to be part of the program. If they're postpartum, we're a little bit more lenient, especially if they're like past that 6 weeks mark, so they might not need, quote unquote, need care. And then typically who refers, it's really whoever sees the need should be referring, in my opinion, but typically what we see are like providers, nurses, social work, and then of course, as I mentioned, Safe Babies. We have a relationship with Jefferson County Jail through Worth, which is another peer organization within CU. And then we do have an established relationship with Arts OTP, which is like what's commonly known as methadone clinics. And then to refer, there's a couple ways. So you identify the need, whoever it is identifies the need, and then there's kind of two routes. If you have Epic, if you have UCH Epic, you can send the chart directly to me with a little blurb explaining like what's going on, and then I'll respond to you, say I got it, and then we'll assign it. Or if you're not within that system, just email me directly with pretty much the same stuff, name, contact information, kind of what's going on, and then I will assign the client or potential client to our CD, and we'll reach out within 2 business days. Typically it's the same day. And then we set up that initial appointment to explain the services, get consent, all of that. And then once someone has consented to services to us, we will begin meeting weekly. Typically it's weekly, sometimes it's every other week, mostly on the phone or Zoom. We also do in person, like at the clinic, at the hospital, things like that. But obviously, hopefully people aren't at the clinic or hospital every week, unless they're pretty far into their pregnancy. And then once they reach that year, we do the closing session, and that's when we make sure that they've been connected to all the ongoing care that they need or want. They have all the resources they need. We kind of close out the relationship with this program, and they get a graduation gift. So labor and admission, since we are full spectrum doulas, again, we can attend labor and delivery and support that. There are only 2 of us, so we can't always guarantee that we'll be there when the baby is actually being physically born, but we do guarantee that we'll be there with you in the hospital at some point, provided you tell us where you're in the hospital. There's no other way we would know, unfortunately. And this is kind of the timeline. So we started providing care in January of 2023, started taking on specifically midwifery patients were our target population in the beginning. In February, we changed that in May, and then in August of last year, embedded in the paraclinic, which is Dr. Kaylin Cleese, like OB, prenatal care, postpartum care clinic here. September of last year, we launched our first iteration of contingency management. And then March of this year, we started inpatient rounding, which basically means that I check in with the charge nurses 3 times a week on labor and delivery and the postpartum unit to make sure that we're getting all of those referrals, and to also, constantly kind of remind them that we exist. And then in May of this year, we launched our support group. So some of our data, you can look at it. I'm going to skip it for time's sake. These are kind of some of the metrics that we keep track of for research and seeing what's working, what's not working, funding purposes, stuff like that. None of this is shared with anyone. It's just within the team for tracking purposes. That's our patient enrollment in the first few months. And so some things that we are evaluating since we are under research is role compatibility. So is it feasible for someone to be dual trained and provide dual services as a recovery coach and a peer? And we primarily do that through pre-training surveys and post-training surveys. And then our research team is also conducting interviews on people practicing in this way. So the recovery coach doulas to see how it's going, basically, if it remains compatible. We're also similarly tracking the recovery coach doula experience. We track client experience through surveys and also interviews. Birth outcome data, which we get from the medical record. We're working on, of course, financial stability or sustainability because we are grant funded. And then always open for team feedback. So our incentives program, as I mentioned, has moved to gift cards. We have changed it throughout the years that we've been around. This book is one of our graduation presents. So the rest of this information is inaccurate right now. So this is why we changed the contingency management, because there were a lot of challenges. At first, we wanted to provide physical items, like physical self-care items, physical baby items, but being a largely telehealth program that proved to be pretty difficult for a lot of our clients who weren't able to come pick things up. And then, as I mentioned, tailored care is a big component of the program. We have like 5 minutes.
Yeah, so one of the pieces that was really important was to make sure that the model that we developed was comprehensive and tailored, meaning, and that's one of the reasons why we have our patients engage in their perinatal or postpartum care within a CU practice, because we really wanted to have the ability to provide the wraparound services that someone may need, either prenatally or postpartum. And so the tailored care approach really puts the patient in the center and then identifies those services that they may need. So that could be midwifery, could be maternal fetal medicine, it could be social work, it could be the cardiologist, right? And so them being within our system just allows us to really have that access to referral in a more comprehensive approach. The support services, of course, are also part of this with the doula services, social work, lactation, and then also part of that wraparound services is really centering the community and providing access to some of the Nurse Family Partnership, Motherwise, and WIC, for example. So just real quickly, our program exists because of community, right? The pieces that we've really pulled together and partnered with are Safe Baby, CPCQC, Integrated Care for Women and Babies. Just want to highlight them. They're our original funder that allowed us to really get this program up and going. Hard Beauty, who's also in the room, and thankful for their partnership as well. And then UC Health is primarily where we're embedded in right now as a program. Just to highlight the one piece, and Britt and I talk about this often, is they're really the eyes and the ears of our program, the eyes and the ears of what the patient is experiencing. And so the piece of the advocacy of this role is huge. And has really allowed us to see where things are going well on the inpatient side, particularly but where things aren't going well for the patient. And so one of the things that we've really prioritized is how do we educate our healthcare teams to make sure that they're providing care in a respectful way. And so we partnered with CPCQC to support some of our SUD implicit bias training. So I'm just going to say billing is hard, and we're not going to spend a lot of time on this. The only thing I would say is that it's been challenging to bill for peer work in the state of Colorado. Thank you. And we're still fighting that little fight. Oh, hi. Thank you for that. So we're still fighting that little journey. We're grant funded right now, so the urgency of that feels less urgent. But the thing that is extremely important, where I'm going to get us to, is that the Doula expansion in the state of Colorado. This allows us to work the system. I hate to say that, but work the system to allow us to bill for this program, right? Until we can figure out the opportunities that exist for peer billing in the state of Colorado, us having a dual certified or dual trained program is going to allow for us to do this work in a more comprehensive, sustainable way, right? We can't exist on grants forever. It's just not sustainable. And so we really need to push, if anyone has the opportunity to really advocate for peer support billing that's comprehensive and, I'm not going to say easy, but streamlined. We need that in the state of Colorado. So 7-1, the state of Colorado now reimburses for doula services for patients insured by Medicaid. So this is a way for us to really support our program. Lessons learned. I'm glad the success side is bigger than the opportunities, but we're still learning, right? I think with any program, we're still making refinements, finding things that work, don't work. We should have done this, we should have done that. But we're still really looking to grow and evolve. Our future is really bright, and I think this is probably one of the most exciting things about our program right now is that we are expanding. We've received some additional funding that will expand into northern Colorado. So Greeley and Fort Collins, yay! There's my people. Hi. And then we're also going to the south, to Pueblo. And so we look for that growth to happen in January of 2025. We're currently hiring for 2 more recovery coach doulas, full-time positions to expand. The piece that Britt did mention, and I think this is really important, is recovery coach doula work is very new. It's novel. There's not a lot of people doing this work. We feel like we're really on a pathway of discovery and want to share information. And that's why the research component is so important. We have a complete research team that's really focusing on identifying outcomes, really looking at sustainability from a financial perspective. How do we integrate into communities that maybe are in rural areas or less connected with systems? And so we're doing a lot of work in this space and are really excited to disseminate and share. And so I just want to highlight our project team. This group has been meeting for 2.5 years, 3 years, every 2 weeks. We've canceled a few, but almost every 2 weeks. Just amazing thought leaders, passionate about this work. And so just wanted to highlight and say thank you to that team. All right, thank you.